So good evening, friends. Welcome to this Tuesday evening session from Yashoda Group of Hospitals. We try to bring some interesting topics for the clinical interest, not just from the Department of Critical Care Medicine. We try to align with other specialties, including either super specialties or our broad specialties. And today we felt we are closer to a monsoon season and we are seeing trickling of patients from different spectrum. We have seen patients with gastroenteritis, a series of cases from some common source, and we have seen some influenza and other flu cases trickling in the last few weeks here and there. And in the last weeks, I think most of our clinicians discussing that we also saw some arboviral, including the mosquito-borne diseases like dengue and other viral illnesses. So we felt these syndromes are not uncommon to our OPDs during this monsoon season, but also some of the syndromes land up to the ICU with a severe sickness. So today we thought we will bring a session on these fever syndromes where it can be a spectrum from a respiratory tract flu-like illness to a multisystem involved leptospirosis or a scrub. So to bring this discussion, we requested Dr. Kaladhar to bring some cases, bring some discussions on monsoon syndromes and fevers. So he will take us through maybe a few cases and maybe 10 to 15 slides overviewing this monsoon related fever syndromes. Then we will take the expert opinion or the panelist suggestions and probably answering the questions from different participants by our three esteemed experts. Three of them were from the internal medicine department. Dr. Sasidhar Reddy Gutta, who is a senior consultant internal medicine from Yashoda Hospital, Malakpet. Dr. Sasidhar, thank you for giving us this opportunity and being a part of this program. We appreciate your time and valuable presence. Thank you.
Thank you.
I also request Dr. Kishan, who is again a senior consultant in the Department of Internal Medicine in Yashoda Hospital, Somajiguda. And he has been a seasoned clinician there. And we thank you for being a part of this program, Dr. Kishan. Thank you for being here.
Thank you.
And again, one of our ever smiling good clinician and a physician and good friend of ours, Dr. M. Seetal Kumar, a senior physician in Yashoda Hospital, Secunderabad. I happen to have some opportunity to spend some time during my part in the ICU in early parts of 23 and 24. Thank you, Dr. Seetal, being a part of this program. Thank you for being here.
Thank you, sir.
So I will request Dr. Kaladhar to just take us through a few slides overview of what is monsoon fever syndromes and what are the common syndromes which we are now coming across. Over to you, Dr. Kaladhar.
Thank you, Venkat sir, for that introduction. And I thank Dr. Shashidhar Gupta and Dr. Kishan Boorugu sir and Dr. Sheetal for coming on board as expert panelists. So I will discuss first the case we dealt with in our ICU. Then probably we'll discuss what are the different syndromes that we come across. Being monsoon ahead, we will be facing these infections. So thank you. Sorry for that. Are you able to see my slides?
Yeah, we are able
to. Yes.
Okay. So this is one patient where is a 56-year-old male with no comorbids. So he's being from near to Miryalguda, presented with fever with high grade since around 5 days. Then he had a generalized body pains along with this fever. And there was a decreased urine output. He was taking some symptomatic treatment at a local hospital. Then he developed decreased urine output since 2 days. Then being it's progressing there, a bit raised creatinine was there around 2 in the local hospital when they tested. So they thought probably this is the acute febrile illness worsening towards possible multi-organ dysfunction. They referred this patient to our center. So when he came to emergency on arrival, he was tachycardic. His heart rate was around 150 per minute, having shock with BP of around 70 systolic. His BP after that improved with IV fluid resuscitation He required moderate doses of Noradrenaline around 0.5 microgram per kg per minute. So then SpO2 was also on the borderline with a respiratory rate of 24 per minute, and there were bilateral crackles on the lung auscultation. So, but otherwise, his mentation was good. He was conscious, following commands, no other vocal neurologic deficits. But on examination, on his sclera, he was icteric, and there is pallor also a bit. And when we looked at it in emergency, the ABG was taken being sick and in shock. The ABG here, if you look at it, is showing severe metabolic acidosis along with around bicarb of 11, along with PCO2 of 28, which is respiratory alkalosis. So the lactates are a bit on higher side, showing like hyperlactatemia, not progress towards lactic acidosis at this point of time. So he was after putting a Foley's catheter, his urine output was low, around 25 to 30 ml, even after a slight guarded resuscitation, because there were creps. We were thinking probably it is a pulmonary edema and all. So when we looked at his heart function was good, not much of any severe LV dysfunction. So fair LV function was there, bilateral B profile was there. So with this background, when we checked his the ABG being on the higher side, the severe metabolic acidosis side, and there is a decreased urine output. And when we looked at his renal function test, it was showing creatinine on the higher side. And then is hepatic derangement, liver functions deranged very much. So concluded that it is probably some tropical fever along with progressing towards multiple organ dysfunction syndrome, being sick. So we initiated early SLED. So it is around 8 hours. Slow low efficiency dialysis was done. So because he's on moderate doses of Noradrenaline, that's what we thought. And he is not very tachypneic. We actually thought of whether to go for intubation at this point, but he's being cooperative, not very tachypneic, and there were no escalating doses of Noradrenaline. We initially started him on NIV support, later HFNC. This was the CT which was done, so which was showing bilateral, probably pulmonary edema kind of picture only, with ARDS being the background. Then we thought, even because tropical fevers, especially the kind of leptospirosis, sometimes precipitate diffuse alveolar hemorrhage. That was also one of the differential initially. But if you look at the ABG after 8 hours before the half an hour closing of our dialysis, it is improved pretty much better, and his tachypnea came down, the shock was getting better, and all this progressive improvement was shown. Actually, this is a improvement which is very drastic. Generally, we don't see these kind of sick patients. They progress towards intubation and worsening, but this patient had a very good turnaround. So when we look at the investigations, there is severe thrombocytopenia, around 28,000 platelets. Of course, progressively they improved. So this is yesterday's, he recently got admitted, around 60,000. Then when we look at this renal function test, the urea was gone up. 6.4 is the creatinine, and 24 was the bilirubin. So when we checked, of course, most of the times the approach is towards ruling out malaria, dengue, and scrub typhus and lepto. These are the common scenarios that we encounter at Malakpet, the Malakpet region. So that is the reason we tested. So when we tested for these, then we got the leptospira antibody positive, around 90 titer, more than 11 is strongly positive. So it is being strongly positive. One good thing in this patient is progressively improved. Only required that one session of dialysis, then actually urine was coming, and urine was adequate without much dialysis. AK improved, and even without going on to ventilation, he could came out. So with this background case, I want to go towards the epidemiology. Probably this is one I was searching for what are the different papers, like the research that is there in India. When looked at, this is published in Journal Physicians of Association of India, JAPI. So the study of clinical profile of patients presenting with complications of acute febrile illness during monsoon, especially during monsoon. This was done in KEM Hospital, Mumbai, by Kaustubh Dilip Salagre et al. So they basically looked at the clinical laboratory profile and outcome of this complicated acute febrile illness, especially between, if you look at July to October. In this graph, if you look at the blue, the up spike is leptospirosis, then dengue is also almost similar to lepto and dengue. Both are at the same upspike, but dengue happened a bit later in the monsoon season, and then malaria, and then hepatitis E. These are the common upspikes of these diseases they observed during monsoon. So they looked at around 276 patients, and then looked at what are the clinical presentations, what are the diverse etiological agents, what happened to clinical laboratory profile. These are all the things they looked at. I will, in subsequent slides, will discuss. So when they looked at the symptomatology of these patients, what are the common symptoms across different dengue, malaria, lepto, mixed infections, hepatitis E, they looked at these are the common symptoms they could observe: headache, body ache, high colored urine, abdominal pains, diarrhea, loose stools, rash, bleeding from nose or mouth, breathlessness, oliguria, convulsions, altered sensorium, nausea, vomiting. But the headache, body pains, high colored urine, abdominal pain, and along with probably gastroenteritis kind of picture is more in these patients. And then they looked at even signs of this complicated febrile monsoon illnesses, where they could find that initially the patient may be having rapid weak pulse, most probably progressing towards shock in ICUs. Ascites, hepatosplenomegaly, pedal edema, purpura, sometimes patient presenting with low GCS and coma. Icterus is also a common finding, and then tachypnea. So these are the different findings they could find, symptomatology and science. Looked at laboratory investigations. There was a group of patients, 7 to 12 grams, that is picture of anemia, probably due to bone marrow suppression, was there. Along with that, platelets, of course, most of the time, this is what we look at in these patients. Most of the times they are bit less than 80,000. So renal function test, especially in the context of malaria, complicated malaria, leptospirosis, we do see this as early as in the illness. And most of the patients had a transaminitis picture. If the patient without hepatitis, most of the times these tropical fevers will have initially transaminitis picture. So the different organ involvement also, they looked at whether CNS involvement, hepatitis, respiratory distress, renal failure, hematological derangement, shock or dehydration. In across all these are the generally the pictures. The picture depicts this chart depicts that around 64, 118. These are all different, like CNS involvement, respiratory distress, renal failure, hematological derangement, shock, and all the picture they looked at. And one more study that was published in 2017, this is in IJCCM, where they could look at what are the different illnesses that the patients can come to ICU. Around it forms around 20 to 30% across the country in different centers. They look at the same time. Dengue, malaria, scrub typhus, and viral encephalitis are the major causes of these tropical infections, which cause this the monsoon spike. Thrombocytopenia and rash is the most common presentation. Almost 35% of the patients who come to ICU required the mechanical ventilation. If you look at in this chart, dengue, scrub typhus, meningitis, encephalitis, malaria, pneumonia, sepsis, leptospirosis, viral hepatitis, these are the most common. Even dengue with malaria, sometimes combined co-infections can also be possible. So generally, we can divide these monsoon fever syndromes into 3 types probably: mosquito-borne diseases, water-borne diseases, and airborne diseases during monsoon. Mosquito-borne, especially malaria, dengue, chikungunya; waterborne, typhoid, leptospirosis, hepatitis, and all. Airborne, most of the times what we get is influenza, the most common things. So generally, when we are considering this monsoon fever syndromes, what are the factors that you keep in mind while asking the history? Especially, suppose we get the patients coming from rural areas, it is most commonly the scrub typhus, leptospirosis, and even sometimes we did see in previous year monsoon, melioidosis also was most commonly was there. So these are the things that you look at, and the waves of epidemics may be different between different regions sometimes. But dengue, malaria also form most of the crux of dengue is most commonly the first it comes, I can say, later followed by probably scrub and lepto, and then probably melioidosis and all. So the region is also like in southern part of India, it may be different. And in the northern part, most of the time, sometimes we do see exclusive to Bihar, there may be leishmaniasis, and South Central melioidosis, mycetoma can also be possible in West Bengal like that. So the region plays a role, and travel history, especially the we did see one patient who went to Maredmilli. I think anybody know Andhra and Maredmilli, and that patient around 30-year-old visited there. Then he presented with cerebral malaria. The malaria is most common in that being a tribal region and all. So recent travel to endemic location and with fever coming, I should always suspect with the disease which is endemic to that region. Socioeconomic state, of course, it's a no-brainer. Most commonly, the low socioeconomic state presents with these infections commonly. And onset of duration sometimes is also very important. But most of them have incubation period of around 7 to 10 days. But typhoid can develop as early as 5 days. Medication history, of course, this confounds most of the times. We do see patients coming from rural areas where the local RMPs give the steroids for any fever. It can initially blunt the inflammatory response, most of the time confounding the background. And the most common practice that even rural areas practice is prophylactic anti-malarial, something like giving a chloroquine. It has been, I think, banned since 2017 not to give for every fever patient chloroquine to not to be given, which may confuse the disease status as such. And severity and family history is also important. Sometimes the patient having influenza, the family can also be getting infected. And most commonly, what across different literature we discuss is syndromic approach of these patients. It is gives a rough idea of what we are dealing with. Of course, in all these syndromic approaches, most of the diseases being included. That is the confusion sometimes, but at least it gives a rough clue. If fever with rash and thrombocytopenia, dengue, rickettsial diseases, malaria, and meningococcal possibilities, fever with ARDS, lepto, H1N1, scrub typhus, sometimes complicated malaria, melioidosis, legionella also can possible. If there is encephalopathy, Japanese encephalitis, herpes simplex virus, malaria causing cerebral malaria, and Neisseria, of course. Fever with MODS, especially initially leptospirosis has to be suspected. With other hepatitis A, dengue, and of course everything comes. There is jaundice, of course, most of the times hepatitis A, E, and E, lepto, and rickettsia. Fever with rhinopulmonary syndromes, typhoid, dengue, lepto can be possible. If nothing much pointing towards sometimes undifferentiated fever, malaria, scrub, this can also be included. So pretty much the syndromic approach they say, but in every syndrome, almost every disease fits in. That is the bit myopic view of the syndromic approach that I felt. So if it is simplified, probably most of the times what we look at in ICUs is differentiated. What is differentiated? There should be a localization of the infection, whether it is localized to lung pneumonia, if it is altered sensorium meningoencephalitis, if it is presented with some pain abdominal urinary. So this is differentiated. If that is not differentiated, pretty much like to any local area, most of the undifferentiated fevers can come under the malaria, dengue, and monsoon diseases. So when we look at where do I start testing? So what are the things that I have to consider, and when I have to send diagnostic modalities to have to be used? So most of the times these patients initially malaria, dengue being very common, first and foremost, any fever coming with these have to be ruled out by default. And there is, of course, as we discussed, if there is jaundice, abdominal pain, typhoid is also, we had a patient where a 18-year-old boy came with consumed outside food, came with, after 1 week, he had severe multi-organ dysfunction. And then, yeah, of course, we could not save him because it was very bad. Later in blood culture, it was Salmonella typhi. So this is also a possibility. And encephalitis, of course, very important. And when there is a fever altered sensorium, don't delay the LP, and do send simplex Japanese encephalitis, very important. Even we did have patients with scrub typhus. I think one of Dr. Shashida's patient where we sent scrub IgM in LP and CSF, then we could get it that it's probably scrub related encephalitis. So blood cultures, of course, if it is a clear-cut dengue and there is thrombocytopenia and you don't suspect any secondary infection, probably blood culture is not needed. The patient who is coming with shock, of course, multi-organ dysfunction, always it's a good idea to send blood cultures. And don't forget about TB. If there is chronic respiratory symptoms and fever with altered sensorium, even in the midst of whatever it may be, the tropical fever, always think of TB also one of the possibility. So Vidal, this is the thing we see most of the times, most misused or abused test, I can say, as being obsolete, but in peripheries, this is the one they use. The moment any patient goes with fever, they do Vidal and they label it as typhoid and be treating with as a typhoid. But the patient later worsens, being missing some important scrub typhus or lepto. That is the reason Vidal is absolute, being a test which is like the patients who is endemic having it, anybody can have a positive test because of prior infection. So typhoid dot, of course, that what we use in ICUs, which also tests IgM, is shown to be around 75 to 80% specificity and sensitivity. Sometimes fairly rules out initially, but blood culture is considered to be gold standard. So, and these are what are the different clues that generally we look at in ICUs is any patient coming with tropical fever. Most of the time, this is bedside most easy. And if we found this type of eschar where scrub typhus is easy, most of the time they will be found in groins, axillae and all. And sometimes the eschar with other tropical fevers like Mediterranean Montanese fever, that is called, we don't see this very commonly. But these are the good signs, rose spots of typhoid, blanching rashes and meningococcemia, purpura, kind of these rashes, if they are seen, they give a good clue towards the possibility of etiological agent. And fever pattern, of course, this is not very much we ask in history being in ICU, but still this history also plays a role. Suppose if there is every 24 hours fever or every third day fever, every fourth day fever, like quotidian, falciparum, nausea, Vivax and ovale malaria, especially in malaria, it helps a lot. In typhoid, of course, a patient who is having a temperature being high, but his heart rate is not to the proportion of temperature. Generally, every 1 degree Fahrenheit temperature, there should be rise of 10 beats of heart rate, but it's not correlating like that, probably related to bradycardia. Early we can suspect the possibility of salmonella. And this is one interesting finding where eosinophil count, if it zero, almost zero, it fairly points towards possibility of typhoid. Different studies have shown it. We don't generally look at it, but the different studies have come across shown eosinopenia points towards in the context of fever, typhoid, and eye and the cord in the differential diagnosis. And when any patient coming with fever with altered sensorium, fairly if the stable and do MRI, these bilateral thalamus and basal ganglia, they light up. Possibility of flaviviral diseases, something like the Japanese encephalitis is a possibility, has to be always looked at. Then a diagnostic approach. Of course, most of the times the routine things we have to look at along with possibly these patients coming to ICU. We should do echo if the patient is having the hypotension, shock, because myocarditis is most commonly seen, especially young dengues and young scrub typhus. They go down very fast. This is the reason we have to rule out as early as possible, and along with, as I was telling, shock blood cultures. And then specific tests, of course, we have parasite V and F, that we call MP malarial test, rapid diagnostic testing, smears sometimes, dengue, NS1, IgG, IgM, depending upon the onset of illness, LPCSF, as I was telling, leptospira, IgM, if the more than 5 days of illness, and we pretty have like urinary legionella can also be sent. Sometimes we want to rule out, this also can be done. TB gene expert, HSV PCR, stools sometimes help, hanging drop, especially cholera, because waterborne diseases also common, can also be ruled out by this. And even we do have multiplex PCR biofire assays. Nowadays, we can use that. Scrub typhus, we use IgM. Sometimes we use immunochromatographic test, ICT, which is rapid one. Sometimes if you want to confirm IgM, is also one of the modality. Rarely, if we are not able to arrive at a diagnosis, sometimes we did use bone marrow culture in some patients. Sometimes these patients land up in HLH, something called as hemophagocytic lymphohistiocytosis, and then bone marrow can help in ruling out that also. And then on the background of this, how we approach generally, I can say this, depending upon the patient who is coming to ICU, the organ support systems are very important. thinking about in early intubation and early probably RRT, because these patients who are bad may not give time. So that is the reason as early as possible acidosis control, and especially ARDS can also be managed. In some patients who have myocarditis, there is a role of sometimes VA ECMO also. Nowadays, ECMO is coming in a big way. And of course, platelet transfusions. The steroids are the one most of the people they use, especially in dengue, I think is absolutely no. And specific therapy, of course, most of the times the crux forms as initially ceftriaxone, doxycycline, but the patient who is having shock, we generally go for meropenem initially, because as broad as it has to be covered, patient being treated elsewhere in the second tier cities and coming here, we don't know, there may be a possibility of secondary bacterial infection already being developed. That is the reason patient being in shock, we go for carbapenems along with that doxycycline forms a crux of this. Other than that, most of the, like one study from CMC Vellore shown that the patients who are scrub typhus, severe scrub typhus, in addition to the doxycycline and azithromycin, it is being published in NEGM, shown to have a good outcome compared to alone the doxycycline along with ceftriaxone. So these, I think the treatment, probably we know all the supportive treatment other than that. And of course, dengue, especially the platelet transfusion, generally we can wait up to 10,000 if the patient is stable. But of course, the rapid fall, it is there compared to the yesterday or day before yesterday values, it is being rapidly falling. Probably 20,000 is the trigger. That is one thing. And along with that, I came to the end of my session. The take-home points are systematic approach, as we were discussing, is very important. The history also plays very important role, along with recreational activities, travel, so and the incubation period, and then probably applying syndromic approach initially to narrow down the list of possibilities. And these are the main disorders that we generally encounter during monsoon: dengue, scrub typhus, leptospirosis, encephalitis, and malaria. And most common, even sometimes melioidosis can also be a possible differentials. Along with that, ceftriaxone with doxycycline or azithromycin can be an appropriate empirical therapy if there is the encephalitis, and cyclovir has to be added, considering HSV as a possibility. So with this, I think I conclude my session.
Yeah, thank you, Kaladar.
Thank you.
That was an excellent overview. I think in that short period, you try to cover the most common etiologies and the case presentation. I think I'll take questions and then probably come back to you for your experience in intensive care unit. Dr. Sasidhar, it has been since probably few weeks where we have seen some monsoon rainfalls in the city of Hyderabad. Have you started seeing cases of this kind of categories which Dr. Kaladar was mentioning?
Yeah, yes, sir. Definitely. Initially, in the first week of June, we had few influenza A positive cases. So patient presented with high-grade fever, mild cold, and cough. So most of them were diagnosed on OP basis. Very few required in the ICU, even went on to ventilator. That were only few numbers, 3 to 4 cases, I think. Dengue we didn't see in the last month, but for the last 4 or 5 days, we are seeing the fever with high-grade fever. Patient are directly coming to the OPD with rash and all. When we evaluated, we found to have dengue with thrombocytopenia, but most of them are stable. Till now, we didn't see any dengue shock syndrome like cases at all. That's the presentation right now we are seeing.
So as you mentioned, we do see respiratory related illness. We have seen influenza, we have seen other viral illnesses. We have also seen few cases of COVID during that on and off period, which were OPD based. Some of them needed ICU stay. But that surge was probably a faint one, which actually died its own course.
Yeah.
And similarly, as you said, we have seen some mosquito borne, more so dengue, and that's again trickling down now. We have not seen much surge, but on and off cases. Coming to Dr. Sital, one is we spoke about the respiratory illness, then probably some mosquito borne. Have you seen some cases with gastroenteritis? Is there been any trends we see, if this time you have seen, or what is generally in monsoon season, is there any trend of increase in gastroenteritis cases?
Yes, sir. From last 2 weeks, we are seeing more number of gastroenteritis cases, but they are of mixed type of infection. In most of the cases, we are getting typhoid IgM positive. In some cases, with the negative typhoid IgM positive, they are getting turned out to be viral infections, mainly hepatitis A and D. They are also presenting in the similar way, but with a prolonged duration. And in some cases, first 2 to 3 days, not on day one or day two. After day two, we are getting acute GE type of symptoms, but the diagnosis is not coming as waterborne infection sometimes. So there is a mixed picture of diseases what we are getting from last 2 to 3 weeks. We had seen more number of typhoid cases, dengue with the similar complaints, hepatitis A and E also with liver involvement and hepatitis. So mixed infections we are getting.
So, Dr. Harikishan, we have discussed that there is again a surge of respiratory illness, surge of gastroenteritis, surge of probably vector-borne illnesses, because you see rainfall or monsoon seasons catches the mosquito breeding also. But coming back to you, to having increase in tropical illnesses and syndromes, and more complexly when I talk about lepto, if I was surprised to see Kaladas, the number of cases of lepto which overtook dengue and other in that particular study in 2016, and other tropical illnesses also followed by that. So what is your experience, and probably your pattern of observation happens during this monsoon season about tropical fevers?
So obviously, if during this monsoon, I think the viral illnesses, mainly the respiratory illness, they, if you look at the incidence wise, they top the list. But often they don't require admission unless they have other co-mobs. So otherwise, it's dengue, I think, is the next, infection which leads the chart for us. So if you look at the list, like rightly you've mentioned, we don't see much of lepto. Right. I mean, we do suspect lepto very often, but we don't see much of lepto. Another problem with lepto is the accuracy of the tests that are available. So we see very often the MAT test. What we rely is the leptospira IgM antibody, and though the maker, whatever they claim the sensitivity specificity, I'm sure many of you agree that we have specificity issues with lepto when we do the IgM antibody. When it comes to the microscopic agglutination MAT test, the sensitivity is an issue, because so many times in pregnant women with fatty liver of pregnancy, absolutely no history of fever. Epidemiologically, it cannot. I mean, leptospira, they have to have some exposure to contaminated water, right? Without that, without fever, we are pretty sure that it is fatty liver, and often we see lepto becoming positive, where we are reasonably certain that it is false positive. And hepatitis A, E, we've seen false positive. So that's the issue with lepto. We don't see much of lepto here. Even in Vellore, during my postgrad days, undergrad days, we never used to see much of lepto. So if you take in 2000, between 2007 to 8, we published a study from Vellore, all the hospitalized patients with acute undifferentiated febrile illness. I'm using the word undifferentiated because straight away you rule out UTIs, straightforward pneumonias with a definite focus of infection. So you're talking about viral fevers, tropical fevers, including malaria scrub. So among hospitalized patients in 2007, more than 1/3 were actually scrub. And the next, it was dengue. Very few leptos in our series. We had some Hanta also. Hanta actually diagnosed by PCR, and then even rise in convalescent antibody levels, paired sera. So the same, they did another study in Vellore in 2016, published by Dr. Abhilash. So there they looked at the outpatient. The first study I was talking about. Even in that outpatient thing, surprisingly, scrub, dengue were leading, then followed by malaria and enteric. So here, I think at least my at Somajiguda, when I see, we rarely come across proven lepto. We do scrubs occasionally here. We do look for scrub, and then we do diagnose occasionally, but dengue is quite often That's something very commonly we see. Of late, enteric. Last 1 year, we've been seeing so many blood culture positive enterics. So that is something I think if we have to give some take-home message, please do a blood culture when they come to OP with 3 to 4 days fever, because we don't have, like Kalada mentioned, Vidal is the accuracy issues. Typhoid also has accuracy issues. Blood culture yield is more than 50% if you do. And
We'll
then,
come to that. We'll come to
yeah,
the tests.
yeah,
I think what your point is, your pattern has more of other tropical illness than lepto in so much.
yeah. We don't see much
It's
of
all
lepto. It's
leaning areas of your geography to your hospital.
yeah.
I'm sure Sasidhar and Seetal will agree with me, and even Kaladhar.
Yes.
Uh, it's not common, but it's not uncommon also. We do see on and off every month a couple of cases here and there of lepto, which are not just about IgM positive, but the spectrum, clinical spectrum.
Hepatorenal
National
involvement.
history.
The problem with
the-
clinical spectrum is that all of them have very overlapping manifestations.
Agree,
See,
agree.
renal involvement, jaundice, respiratory, hematological, be it dengue, scrub, malaria, all of them have. See, except for scrub, which has, if you pick up a typical Eschker, which is pathognomic, or the typical clinical course of dengue, where you have the classical dengue features, the fever. After resolution of fever, then they start worsening with hemoconcentration, serositis. Otherwise,
Yes,
for the rest, it is very overlapping manifestations.
agreed.
So
agreed.
we make probable diagnosis,
Yes.
and we all have a hunch it is that, but it is unfortunately it's a difficult area in the absence of a very accurate test.
Dr. Hari, the problem there is with many other diagnostic tools also, the accuracy, sensitivity, specificity, the tool with you is all. And I also probably bring that topic of which you mentioned, scrub being one of the, what you said, differentials was listed into our undifferentiated fever is with those papers from CMC Vellore, where the scrub was considered to be one of the most common undifferentiated fever. And Dr. Kaladhar was mentioning about a paper which is published in the last year in NEGM, which we all take the pride about when a paper of randomized control trial published in
Combination therapy is better. Yeah.
That was again
In
related to
situation.
the scrub and severe scrub, moderate to severe scrub.
Yeah.
combination
Right.
therapy.
Right.
I think we do saw that kind of pattern with the maybe the coastal part, which that the undifferentiated fever, the scrub being a leading possibility. Coming back to the other parts, Dr. Sasidhar, when these patients comes to you, so are they from a primary center or they directly come from their home or their own place to you? Is it as this being a tertiary care center? What is the pattern you see? Most of them
Generally the cases which get admitted and in the ICU under physician care or critical care, most of them come from the periphery side. Especially for Malakpet, we get cases peripherally from Nalgonda district, Khammam district, and Mahbubnagar district. So especially in the rainy season, once the rainy season starts, when they start cultivating or just plowing the land. So most of the patients get once they start watering the fields and all. If they get fever and they are having AKI, hepatitis with some part of pneumonia, so we do first scrub typhus followed by leptospirosis. We have seen many cases, sir. Initially, as Dr. Kishan was saying, leptospira spectrum, similar spectrum will be there in the other diseases also. So initially, when the patient comes to us in 6th day or 7th day, when we were not sure, we were starting on ceftriaxone and doxycycline. After second week, if the patient is in the second week of fever, still we don't get anything in the cultures. There are few cases we have repeated the leptospira again, IgM, where we found to be positive, which was negative in the first week.
Agreed.
Just to confirm whether it is really leptospira after ruling out the rest of the infections. Malaria is negative, dengue is negative, scrub typhus negative, other pneumonias, viral pneumonias, everything is negative. Hepatitis A, E negative. Then patient is fitting into leptospira, but still we don't have the diagnosis, and cultures we don't have anything in the cultures. So we are seen positive in the second week, where it is strongly positive. And the case which Dr. Kaladhar has presented, it's positive. The value is 89. So it's very strongly positive, sir. As MAT is the test, but MAT test routinely we don't do, and the availability is also a problem. We are relying on leptospira IgM where the clinical scenario or the clinical picture is fitting into leptospira, where all infections are ruled out. Most of them, all means whatever we see in these particular 2-3 months, common causes of fevers are ruled out, then we should definitely consider leptospira. And in fact, we have seen a few cases where leptospira as doxy nowadays is used on OP basis in periphery also. So most of the patients are not responding to doxycycline. So we have in fact given benzyl penicillin also, where the patient has responded. So in that way also, definitely, because we get more cases from periphery. So our streptyphus leptospira is definitely more in these Malakpet areas.
Well taken points, Dr. Sasi. I think one point you made is even it is a standard of care that in the strongly clinically suspected cases, in the first week, if you get a negative IgM, is supposed to be repeated in the second week to actually reconfirm, include or exclude. And I think that's a best practice. And sometimes we do see co-infections. And the simpler form is probably empirically whatever we treat them, either as ceftriaxone or doxy, most of the times it covers that spectrum. And there were a debate, I will not go into that mild or very minimal symptomatic patients with antibiotic, without antibiotic, leptospira probably progresses in the same way. But we are talking about probably a sicker group, which Dr. Kaladhar mentioned, with multi-organ failure. In most of those cases, as a intensive care experience, we used benzyl penicillin in a standard format and added steroids in them when there is a capillaritis with alveolar hemorrhage with a 1 milligram per kilogram of methylprednisolone. And I have seen dramatically compared to bacterial sepsis and other, these patients do relatively well, and they have a good proportion of them do well. So I think that actually concludes the very wide spectrum of leptospira which you spoke about. Yeah, probably there will be some sensitivity, specificity issues, and even sometimes we empirically treated some of the leptospira cases where we clinically felt with some conjunctival suffusion, typical history, a farmer with multiple organs. We didn't have time. Some of them responded where leptospira IgM came negative. So we will come back to that. Dr. Seetal, second part is we spoke about spectrum syndromes. So you rightly pointed out just before the beginning of the session that when we are discussing about different diseases, many of our cases will not fit into one diagnosis, or you don't get any diagnosis positive. So we probably only try to find out etiological a organism based on the different permutation combinations of their presentation. But at the end, probably you also land up in not getting any diagnosis, and you finally land up in treating them as a unknown etiology one. So what is your experience in that? How many of these syndromes, as Kaladhar mentioned, fever with thrombocytopenia, fever with jaundice, fever with meningoencephalitis or fever with altered sensorium, and the last one is fever with multi-organ failures and hepatopulmonary, hepatorenal, and these are the syndromes which we put across. We try to put across them into different organisms. So how many times you get a diagnosis, how many times you don't get an answer?
Sir, as we are in tertiary care center, we are getting the cases from the referral centers which are already in the complication stage. So in case of these spectrum diseases, the main pathology, if you observe in dengue, in leptospira, in scrub, in hepatitis, everything, the central role is inflammation. The activation of cytokine or cytokine storm or excessive activation of inflammation, this is the main pathology. So we will get the cases in such stage that multi-organ dysfunction is already developed. Whether it is diagnosed as lepto or not, or hepatitis or not, that's a secondary when we get the patient. So the patient will be in the sepsis, multi-organ dysfunction, sometimes already intubated and on ventilator support. So we have to deal with the shock and all those complications.
Dysfunctions.
First that one. So then by default, as Shashidhar sir pointed out correctly, anyhow we are going to add doxycycline in all cases. So first we have to rule out other causes like dengue, for example. In dengue, even in complicated cases, we should not use steroids as there is no role, or sometimes it will lead to further complications. If we can rule out those diseases where the steroids are not useful or harmful, then we can add steroids in case of leptospira where we are getting good responses. So in other diseases with multi-organ dysfunction syndrome, then we have to first save the life, for which we have to give the organ supports like renal replacement therapy and treating the shock, supportive of inotropes, all these things. In severe dengue cases, we may have to go for colloids also sometimes. So all these life-saving measures, first we have to start here, then we have to come to the conclusion simultaneously. So if the patient is having lepto with the clinical spectrum, because nowadays we are getting all type of investigations available, especially in hospitals like ours. In places where the diagnostic investigations are not available, then we have to judge it on clinical this thing only. So on the suspicion basis only, initially we have been trained in government hospitals when we were doing PGs. On the clinical spectrum only, we used to start the doxycycline and ceftriaxone. So if that he is the patient is on ceftriaxone or not, we have to go for higher antibiotics in view of the sepsis and multi-organ dysfunction here. So first we have to save the life, then we have to simultaneously come to a conclusion, then we have to add specific medication for the specific disease.
So, Dr. Sital, you are trying to say that whatever may be the etiological agent, the host responds
Yes,
a dysregulated way. Where
yes,
you're saying it can be a cytokine storm, or it can be any systemic inflammatory response, how the body responds to that infection, leading to organ dysfunctions, are the most common patients who presented to your inpatient or ICU. That's what you mean to say.
yes,
And in them, irrespective of the etiology, whether it is a dengue, whether it is a scrub, whether it is a lepto, or some salmonella, your organ supports remains the cornerstone to save the life. Then
yes,
empirically you use these antimicrobials like ceftriaxone, doxy probably covers most of them. Then you evaluate further. And when there is also a other differentiated fever comes into play, like urinary tract or lung or some other things, probably you escalate to a higher beta lactams in those situations. But
yes.
in extreme, in a good proportion, I was just trying to ask you, what is the proportion of patient where you don't get a conclusive answer?
Yes, sir.
So how many, what will be the percentage it will out of maybe 10 cases which comes like this with organ
So
involvement?
10 to 15% we are still in diagnostic dilemma. So
So
where every test is being positive, and as Shishdhar sir said, we are repeating leptospira IgM after 1 week, and then we are getting a positive report for that.
So there will be still a 20-30% of cases where you may not have a conclusive diagnostic here.
Yes, sir.
Dr. Hari, there is a question for you on the tropical infection. Hari, can you switch on your camera?
Yeah, sure.
So
Yeah.
the question is, as everybody felt, if a patient comes with this kind of monsoon syndromes or a fever with something, empirically we cover them ceftriaxone, doxy, evaluate them with all these diagnostics, and then we come to conclusion. So, but what are the tropical illnesses which are generally not covered by doxy and azithromycin? If somebody empirically started them not responding, something like that. I think one of our doctor has asked the question.
Yeah, doxy, that's a drug of choice for scrub, does help for lepto, but in the severe form of lepto, that is not the drug, right? Ceftriaxone is better. Okay, enteric, azithro, off late, the response has not been great, and azithro on, as a monotherapy won't be a very good choice. So actually, tropical fevers, what we generally choose is ceftriaxone doxy rather than doxy azithro actually, because ceftriaxone is covering your enteric. It is for leptospirosis. Doxy is covering for scrub. Viral anyway, it is supportive treatment. Malaria, obviously, it's easy to make a diagnosis most of the times, and the treatment is totally different. Doxy does have a role as an adjunctive therapy to artesunate. So otherwise, the tropical infections that we see, the scrub, lepto, I think, this ceftriaxone doxy combination and enteric, that combination works well.
So I think what you pointed out is inpatient patient present with a tropical illness, suspected tropical illness, till the diagnosis comes. Ceftriaxone plus doxy is the preferred therapy.
Preferred, yeah.
With doxy and azithromycin.
Yeah, that's what I feel.
Come across a scrub being positive, probably we are considering azithromycin
Then,
plus doxy
yeah,
as a preferred choice over others.
right.
And
The combination therapy for critically ill scrub typhus. Yeah.
in ceftriax and doxy, the combination is, as you mentioned, we think about salmonella being one that is covered with your ceftriaxone at least in the beginning. And if I have a salmonella being positive, if I wanted a not to take a chance, and in Indian scenario, I wanted a cross cover, probably adding a stopping doxy, adding azithromycin in a gram of
Yeah,
it.
agreed.
Makes sense in the situation like
Yeah,
that.
right.
And if
right.
I get a scrub positive, I drop ceftriaxone, add azithromycin.
Yeah.
If I have a patient who is having a lepto, probably if you are comfortable, continue your ceftriaxone with doxy, which both of them had a equally effective. Yeah. Some of us, it's our preferences of a sick patient severely not responding. We also prefer benzyl penicillin over ceftriaxone, but that has no actually robust scientific data at this point of time. But as a preference of choice, we do that. So I think that's overall it covers that spectrum. There are questions related to saying I'll ask Dr. Sasidhar, can I use nimesulide in dengue? We say ki when you have a thrombocytopenia, avoid NSAID.
No, absolutely no. So because what we see is, and generally most of the patients when they get fever, they go to RMPR or they themselves they can't tolerate the severe headache in this viral illness, not only dengue. They start taking naproxen and all. So if you see a patient taking nimesulide or naproxen, what we observe is the platelet falls in dengue on fifth day or sixth day. Patients who are on NSAIDs, their platelets start falling even on third day also. So no IM injections for fever. For that matter, in India, especially in our southeastern area in monsoon season, for any fever, better not to take any IM injections. If the fever is very high, better to go for IV paracetamol. No initial steroids, no NSAIDs, no naproxen for headache in fever, especially in fever, especially in this monsoon season.
So probably I'll ask a contrary question. So you said NSAID should be avoided in any form of dengue patient or a suspected dengue patient with fever and rash and headache and body pains in areas where there is no definite diagnosis. But somebody in a rural area had a very, very high grade fever, paracetamol, a gram orally is not enough. What other alternatives they can use? You said IV paracetamol, maybe in places where it is available. What other way you handle them? This is a very, I know it's a tricky question. There's no definite answer, but I want.
Nowadays, even oral paracetamol 1 gram is available, sir.
Okay, that is helping well and good. And sometimes we do see these fevers coming every 4th hour. We must have been seeing
so every sixth hourly you give a oral paracetamol followed by tepid sponging is the best thing.
Tepid sponging. You will wait there and allow the fever to be there.
No, we'll be getting continuous sponging till the temperature is normal. I'm not saying wait for that. Continuous sponging till the temperature is normal.
So you keep on doing a tepid sponging and come back to that normothermic state or whatever, at least drop the fever at least.
Yeah, especially if I'm suspecting dengue and all, I'll not.
So Dr. Seetal, I have seen pediatricians also considering giving mefenamic acid as one of the alternative or ibugesic as an alternative. What is your take on that? Avoid in dengue can be considered in other or avoid that in all situations?
Yes, sir. In kids, usually some kids won't get response with the paracetamol. I have seen pediatricians preferring brufen and mefenamic acid.
Ibuprofen.
Both have bleeding tendency in a patients who are with a normal platelet count also. If they don't left with any choice, first at least check with the platelet count, at least. So then you can go for mefenamic acid and ibuprofen to get the response immediately, but not as frequently as paracetamol.
Okay. So Hari, there are questions related to the criteria patients with febrile illness to be admitted in ICU, giving such a varied presentation. Do you think there is you use any predictive model scales or anything to see the trajectory?
I guess we have very low threshold to admit to ICU. Obviously, if they're requiring, if they're hypotense, they're in shock, multiple organ dysfunction, we obviously keep them in ICU. So see, the criteria that you use, it really depends on the center. So we have a very low threshold for dengue patients, to shift to, because you want to monitor them closely, the frequent PCV monitoring, the hydration, all that. So multiple organ dysfunction, definitely. Shock, definitely. High requirement oxygen, definitely. So it's the organ dysfunction, shock, that that prompts us to shift to ICU. But however, in most corporates, I'm sure we have a low threshold to shift to ICU because of various reasons.
So it institution wise there may be a different criterias, but
Warning signs we
several-
have to observe, sir. Sorry to interrupt. Warning signs, especially if you are talking about dengue, there are some warning signs where we have to triage the patient to ICU or non-ICU. If you can monitor the patient at room side with the meticulous attention, you can keep the patient even with the platelet count of 10,000 without any bleeding manifestations, who is not requiring any oxygen support. So if the patient is in shock or going into impending shock and platelets with bleeding or rash and hepatitis and mild altered sensorium requiring minimal oxygen support, better to keep him in at least a step down ICU, if not in ICU.
very interesting point raised by Dr. Seethal. One is warning signs. The other point he made is low platelets. I want probably all of you, the four of you, including Kalada, to comment on. Thrombocytopenia has been a serious concern, not to the clinician, but to the family or even to the society. The platelets are low. But my observation and experience in the dengue seasons is isolated only thrombocytopenia without any other early warning signs or a warning sign has never been seen to be as a predictor of mortality or outcome. It has been hyped and created like a worry of concern with SDPs being transfused or RDPs being transfused. But as you rightly pointed out, early warning signs, I see a hematocrit being very high. I see a polysaccharide being there in an ultrasound with gallbladder being edematous. I have ascites. I have a pleural fluids being accumulating, and the patient looks boogie and edematous on IV fluids. Abdominal pain, nausea, vomitings, and many more. Your LFTs being RFTs being dearranged, or your coagulation being dearranged. Those played a major role. And the later part, as you said, probably hypotension and organ dysfunction being a terminal concerns, but these played a major role than just a thrombocytopenia, which counterly many of the families keep on bothering. What is your take, Kaladar, on that? Thrombocytopenia, what is your... See, most of those patients just walk out of the ICU. They are all like a hypoglycemia patient coming, you give 25% dextrose, they will be all right and go home happily. You get all credit. Something like that, thrombocytopenia recovers
Recover
spontaneously.
very well. Yes, sir. Yes, sir. As you said, it is most of a family concern. Yeah, most of the time the family comes, sir, my patient platelet count is 30,000. Why are you not transfusing? If bleeding happens, what? So they put undue pressure. Most of the times we tell them it is not the thrombocytopenia, it is the capillary leak, we call it as, where the blood leaks out, and that is the most problematic. That is the reason we are giving good IV fluids targeting the plasma leak, whatever is happening. So that is the most concern. We have platelets handy. If required, we will use it. Don't worry. Just in case if it is a rapid fall, most of the times we ask them to go for screening and all. But most of the times we try to reassure them. So most of the times even we do see that what is that called? I forgot that papaya extract or something. They ask us to give that papaya extract also to improve the platelet count. Carica papayas.
Caripil, Dr. Sasidhar, there are questions in the chat box. Carica papaya leaf extract.
No, sir. No.
So what is your take? How do you convince your families?
Sir, generally the patient, as you know, sir, first any patient, decision is clinical, sir. Whether to keep the patient in the ICU or in the room or ward or whatever it is. And for example, if you want to keep a patient in the ICU, depending on the platelet count, all the hospital beds should be at least 50 to 60% of the hospital beds should be in the ICU during the peak season. So any patient requiring means 2 to 3 organ involvement, or at least not the thrombocytopenia is not the criteria to keep in the ICU. Patient requiring oxygen or patient in hypotension, patient with AKA, patient with maybe impending respiratory failure. So these should be the criteria to keep the patient in the ICU, because any patient who comes after 6 o'clock or 7 o'clock, they go to the ER. So any patient coming to ER with fever, with thrombocytopenia, we can't keep everyone in the ICUs. So we have to do the proper triage with the patient. If there is any drastic fall, for example, yesterday platelet was 1 lakh and today he comes with 120,000, 30,000. So we need to see, because why then generally we don't see that much fall in dengue patients. Generally we see 20,000, 30,000 per day. If there is a drastic fall more than 50 to 60,000 within 1 day, so those cases might require more observation or more monitoring. Then that would be the criteria for platelet, but only platelet is not the criteria to keep in the ICU. So during dengue season, if we see most of my patients will be in the room or what, even at 10,000, we don't give platelets, sir. As you are asking how to convince, we will tell the family. For example, if the patient didn't bleed at 50,000, he might not bleed at 40,000. If I give SDP at 40,000, if he again bleeds at 10,000, I need to give another SDP. So one thing is, getting a donor is not so easy for SDP. And most of the
risk, they also carry their own risk.
Yeah, so it has some risk. So giving transfusion is very easy for us. Even we can give RDPs from the blood bank, but transfusion has its own this thing. Transfusion related trial is there, because already patient might be having borderline polycirrhosis with mild ascites and all. So there are few indications for definite indications for transfusion. That's what we try to convince the families. But as Dr. Kaladar was saying, even whatever we convince, there are few families, they might ask, no, sir, give us. We have a donor, give us. Then definitely we are giving, but most of the times we are strictly following the guidelines. Better not to give platelets. No platelet transfusion below 20,000. If there is a bleeding and below 20,000, give platelets. No bleeding manifestations less than 10,000, give platelet transfusion. These are the two only indications, sir. So that's what we are following.
Yeah, I think what I have seen over the last a decade or so, in the 10 years, good standard medical practice probably came forward over and above those all probably wrong beliefs. And now most of the standard clinicians have stopped giving platelets below those thresholds of 10,000 or so, except in extreme situation. And that's what I have seen, a probably evolution of a good standard practice over those all false beliefs. I will take last two questions, and probably we are crossing our time. What will be our cutoff reason to give FFP, Dr. Harikishan?
FFP in what?
In any of these multi-organ.
So the FFP, the standard indications, the transfusion triggers, if the patient has bleeding manifestations with coagulopathy, deranged PT, APT, that's the indication for FFP. Unless the patient is for a procedure and has coagulopathy, in the absence of bleeding, we transfuse them to, make them fit for a procedure. Otherwise, in the absence of bleeding, it's close observation most of the time.
So it's a marker of your maybe liver dysfunction or a coagulopathy rather than
coagulopathy, yeah.
Yes.
And
Yeah.
giving a FFP is probably mask
and
marking.
Yeah, and the platelets thing, like that's a good thing that you brought out. Actually, if you look at the dengue severe features criteria, WHO criteria, thrombocytopenia is not a criteria.
Exactly.
It is only bleeding. So it is, yeah. So that's something I think it's nice that you brought it up, because
even in WHO, I have not seen a bleeding as an indication to give thrombocytopenia. They say if that is the DIC situation where everywhere it is bleeding, you probably replace packed cells and other factors. Not even giving a platelets at that time help. There is another interesting questions to you, Dr. Hari, related to use of colloids. So we have seen capillary leak is a very tricky situation. One side we say it's a hemoconcentration because of capillary leak. Your hematocrit is rising. Your patient is hypovolemic, intravascularly depleted, but they are leaking into the capillaries. So what is the role of crystalloid versus colloids? We do understand crystalloids are generally the first line of IV fluid of choice which we give. But if the capillary leak is too bad, what can be the alternative choice in colloid? And I have actually worked in and around this for last couple of years or so to search from different literatures. Dextran was talked about, albumin was talked about, many other colloids were discussed about. What is your take on that role of colloids in them? No, I'm
So
not
if
talking
we,
about gelatins or starch. We are talking about some
dextran or
dextran or albumin.
so if we look at the resuscitation protocol given by WHO, right, it does clearly say, like rapid fluid resuscitation with crystalloids initially, but if it's not improving in the absence of bleeding, they do give you an option of using things like dextran, right? So it is there in the guidelines. But obviously, one thing we need to watch for, if they're still not improving, look, see if the HB is dropping, if there's evidence of bleeding, then we have to give blood products there. But otherwise, even in the guideline, if they're not improving with crystalloids, which is the first line thing, despite adequate crystalloid infusion, then we can consider
So,
colloids.
do you still prefer dextran or you use albumin? That's the question in the chat box.
I think you're better.
So what we generally do is I have searched this literature comparing albumin versus this. We do know albumin comes with its own baggage of complexities, but at this point of time, when a patient comes to us with refractory shock, with myocarditis, intolerance, see, fluid responsiveness is one side, fluid tolerance is another point.
Yeah.
So if I give a couple of liters of fluid in the ER, just looking at a hypotension, my myocardium is already down. Probably I will have a patient with in no time in a cardiac arrest situation doing a CPR. So in those situations, we start with vasopressors, see whether these patients can tolerate small aliquots of crystalloids or colloids. And we do use, let us not hesitate to talk about colloids like 20% or a 5% albumin in aliquots to see whether these patients are responding, not in liters. Last question to Dr. Seetal. HLH, patients responding well, doing well in the first week or so, but second, the fever continues, you see a leukopenia happening, you see the patients being inflamed, so, or a dengue patient continuing fever beyond 10 days. How common is HLH? How do you diagnose and
In
manage?
last 1 month, we have diagnosed 3 cases of HLH. So one, the patient has succumbed, not responded to any of the medication. And 2 patients where one patient I remember came from NIMS. So they have the patient attendants were very curious as the patient is not getting improved and the WBC count is going down to 400. So in that situation, patient came to our center where we have evaluated everything and diagnosed as HLH, and that patient improved. But still, in the follow-up also after 1 month, his WBC count not reached the normal bottom value also. So third case, the patient completely improved, she got discharged. So nowadays we are getting the same thing what I said. Cytokine storm or abnormal immune response. All these things are leading to HLH. In cases where the diagnosis is not accurate or not coming to diagnosis, we have to suspect all these abnormalities, HLH like things. So we
So,
are seeing the cases and the frequency of these cases are increased.
so that's the same spectrum as you said, dysregulated immune response from cytokine storm to HLH or macrophage activation syndrome is the same spectrum. I think
Yes.
what you pointed out is in these infectious agents, when normal pattern with normal antimicrobial, after settling all possible things, if the fever persists and you see a cytopenia, high ferritin, high triglyceride, inflamed situation, probably considering HLH on
HLH.
card should be on that. So I will take a final take home. Kaladhar, you had a wonderful presentation. You brought all the 3 seasoned clinician on board. What is your take home today before we conclude?
Thank you very much, sir, for that comment. So, basically, I think these patients who come to ICU need a multi-modal approach because they are very sick. As we are discussing severe cytokine storm, so the organ support as early as the directed therapy towards that is very crucial. Along with that, the empiric therapy is almost the same, but of course, the differentiation between patient having shock versus not having shock, probably escalation has to be done. One point I wanted to just share with you is regarding the role of plasmapheresis in patients of severe dengue and the leptospirosis with DAH picture where it is vasculitic nature. Probably this is the one when the patients are not responding, every institution may help, especially those patients who are young. We had some cases where there was a good turnaround along with some extracorporeal therapies, sometimes using like filters and all, can also be tried in patients, especially the young with severe cytokine storm.
I
Thank
think I take that point, both plasma exchange and probably extracorporeal filters. Both of them are not a part of any standard of therapy. Both of them are in experimental modes and as a rescue therapies has been used in some of those situations where the other all modalities failed and there were small pockets of information, including your information, which you're talking about, can be considered. Dr. Sasidhar, any take-home point today?
Take-home point is, sir, so as this is monsoon season, so we expect dengue, leptospira, scrub typhus. So any patient, my point is, don't start antibiotic unnecessarily unless we get a diagnosis. So initially, any diagnosis also, for example, dengue, anything to come positive takes 2 to 3 days. So if the patient has fever, initially take paracetamol every 4th hourly, 6th hourly, or if the fever is very high, you can take 4th hourly also, and maintain well hydration. After 48 hours, if the patient is on OP basis, test for malaria and at least basic CPP, CUV. If there is suspected malaria, then we can treat with anti-malarials. If there is borderline thrombocytopenia, borderline leukopenia, then we need to suspect a viral infections, maybe typhoid also in the after, because we don't get everything in the first 5 days. So repeat a CBP on 5th day, and if it is fitting into dengue, go for evaluation for dengue, and if it is the persistent fever spikes, then test for typhoid. And if at all there is a derangement of LFT and renal, test for a scrub typhus, because generally scrub typhus, scrub ICT, which we do in our hospital, we see by 5th day we are getting positive, sir. For example, there are few cases where for any fever case we are sending scrub ICT was coming positive. In those cases, what we did was, because IgM was taking a bit time, it was taking 3 to 5 days sometimes. So if there is a strong suspicion and the patient was not sure, if the other clinician or the intensivist or the other physician is not, it seems that scrub ICT is coming positive for everyone. So we do scrub IgM ELISA also. And in one case where the patient came to our hospital in a severe meningitis, patient was having all signs of meningitis. MRI was showing meningitic features, but it's not a bacterial meningitis. So scrub ICT came out to be positive. IgM ELISA, it takes 5 days. So that what we did is we have done a CSF analysis and sent this analysis. In that also we got scrub typhus positive. So if there is a strong suspicion, and if you are ruling out other causes, and if you are very sure about one diagnosis, better evaluate in depth in that diagnosis so that definitive treatment can be given to the patient. For example, anyway, most of the cases respond to basic ceftriaxone doxy. But what the cases which we get are, they are already treated with oral doxy or oral some cephalosporins. Then we get the cases. So we can't say that I'll again treat with ceftriaxone doxy, because those are already used for 4 to 5 days. Then only patient comes to our hospital, even on OP basis most of the times. So the high index of suspicion should be there, and we should narrow our diagnosis to at least 2 to 3 diseases, at least in the first 48 hours. And definitely any patient who comes to us after 48 hours, first send blood cultures, then only start antibiotic. Even in the ER, even if the patient is in shock, try to first send culture, then give the first dose of antibiotic. So because once, at least outside they don't come with cultures, at least we should give an attempt to find what exactly is the infection. So that sometimes if something turns out to be MDR or some sensitive antibiotic has come, we can immediately change to the antibiotic and results will be very fast.
So you emphasized that you should have a diagnostic stewardship and diagnosis should be approached. That's what you're trying to make.
Yes.
Dr. Seetal, any take home?
Sir, in centers where we are working, I think we should be aggressive. So some cases we have seen young patients deteriorating rapidly within 2 to 3 days of first episode of fever. So first, I will consider proper history is very important. Even in patients where animal husbandry is not there, we are diagnosing leptospira because of multiple reasons: contaminated water and going to places where the water logging is there, and fields and water grounds are contaminated with animal excreta. So all these places where we can't expect that everybody will get leptospira, but some patients. So patients with comorbidities, we have to be very attentive. If the patients are in close observation, or they can come back once we can think that we are able to treat them on OP basis, then we can observe them on OP basis. Second one is categorize the patients who can be treated on OP basis, like without any warning signs, 1 or 2 days of fever, without any family history of these uh, inflammatory abnormalities or cytokine storms. If you take proper history, they'll give any allergies, any eosinophilia history. In those patients, without any history, with a 1 or 2 days of fever, we can wait for the diagnosis, and we can wait for the patient to either improve or deteriorate. Second category, patients who are at the verge of getting admitted, like patients in borderline low blood pressure, where the platelets are in decreasing trend. We can better observe in ward at least, so that if the patient anytime deteriorates, we can at least shift them to ICU. So basic points what clinicians miss in dengue cases, for example, we have, according to the guidelines, only 3 things we have to observe. First one is PCV or hematocrit. Second one is PTINR or bleeding abnormalities. Third one is polycirrhosis and shock. These 3 things usually they miss. Everybody will concentrate on CBP and low platelet count. That's all.
True.
I have seen the prescriptions or investigations without any liver function tests in patients who are having fever. So nowadays that became a basic this thing, LFT abnormality, so that we can differentiate multiple diseases in leptospira, scrub, hepatitis, and dengue, which is going into complication stage. So if you categorize them, then you can decide at the OP itself or at the first observation itself into admitting cases or non-admissible cases. So in cases of comorbidities and the patient at the verge of hypotension or going into hypotension, rapid decrease in the platelet counts, abnormal PTINR, better to admit him. Nothing wrong in that. So patients who are coming on day 5 or day 6 of fever, which are not properly treated or not responded properly, who are coming into casualty, we have to admit them by default. So these things I will.
You emphasized on categorizing early warning signs and the situations where you need IP admissions and early aggressive therapy when there are organ failures and in ICU. That's what
Yes.
you wanted. Hari, what is your take home?
Yeah, I'll be very brief. So I'm talking about OP scenario. People with short duration febrile illness, good history taking, like Sheetal has mentioned, Kaladhar has told, including travel history. That's also important. And consider doing a blood culture beyond 3-4 days of fever.
Agree.
Consider doing a blood culture even for OP patients.
True, agree.
Yes.
Perfect. So I think that's a perfect take-home point. If somebody comes to a medical attention after a couple of days of fever and we are in a tropical suspicion, all of these suggestions are well taken. And I thank all the 3 expert panelists being here for an hour and expressing their experience and wisdom over here. And I thank Dr. Kaladhar in bringing this case and the discussion. And I thank all the participants for being there for an hour. And that was an actually a real world problem right now. I think that will continue for another couple of more months. And in probably coming months, once one of these tropical illness oversets all of that, we'll bring one of those illnesses in a more spectrum way. We'll talk about capillary leak. We can talk about cytokine storm. I could see many questions related to HLH. The therapy related to HLH, yes, etoposide is being given as a therapy for primary HLH, but in secondary HLH with a ongoing infection, sometimes we only limit ourselves to steroids, and then once we rule out all other infections, probably we switch for etoposide with an hematology being involved. And I think we will bring all those details in one more extensive session in the later half. I thank all of you for being here, and I conclude the session. Thank you very much.
Thank you.
Thank you.